Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a posterior subcapsular cataract. Let us observe management of this case under topical anesthesia. Few drops of proparacaine has been applied over the ocular surface. The main incision has been made, and this is phenocane, which contains xylocaine, tropicamide, and phenylephrine. This is 2% hydroxypropyl methyl cellulose, filling up the anterior chamber. And this is a side port on the left side of the main incision. There is a small pterygium in this case. We are not going to do anything of the pterygium in this setting. Now capsulorhexis with utrata forceps, and this is just a copy of movements of Dr. Neto Rosatelli of Brazil. I learned this technique from Dr. Neto, this technique of doing rhexis. Now hydrodissection is done and hydrodelineation also done. I didn't try to rotate the nucleus. Now I am going to use this pre-chopper designed by Dr. Suhail Irfan Khan, and see how beautifully you can divide the nucleus into fragments in few seconds. And I have divided the nucleus into 3 pieces. Visco is injected again, and now I just have to go in and pick up the divided fragments and emulsify. The machine being used is Oatley Cataract 3. The phaco needle goes in, bevel down, and it starts picking up the fragments. In a few seconds the fragments are emulsified. Ultrasonic energy used is only 40% in this case. And now how to remove this epinucleus? Try to pull the epinuclear sheet towards the center. Now I go to the left side, and here it is, it flips. Once the epinucleus flips, you can say this is already managed. Now at this time I go to Phaco 3 mode during emulsification of the last portion of the epinucleus. Now the cortex has to be cleaned. Inject a little bit of visco, and now this is a 23 gauge Simcoe cannula. It is being used to remove the cortex. Simcoe cannula is a very safe instrument for removal of the cortex. And now we can see there is some subincisional cortical matter, and this is going to be difficult to remove this. So what I do is I take a keratome and make a port going through the conjunctiva at 7 o'clock, and now I go through this side port and remove the subincisional cortex. See how beautifully you can remove the cortex if you make a 7 o'clock side port. It is necessary in some cases, not in all cases. And now this is polishing of the lens fibers that were sticking to the posterior capsule. And after this is hydroimplantation of a single piece monofocal intraocular lens. The lens goes into the capsular bag. This is hydrophobic material. Yes, hydrophobic material is very good in this aspect. This is posterior capsular opacification is much less with this material. This is a bit of moxifloxacin. Now the side port on the left side of the main wound is hydrated. The side port which was made at 7 o'clock going through the conjunctiva doesn't require any hydration. And now this is the final lavage of the anterior chamber. The anterior chamber is formed in this way and the integrity of the wounds are checked. Note that the main wound has not been hydrated, but still it is nicely sealed. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Whenever there is a thick sheet of epinucleus, we should gently pull the epinuclear sheet towards the center, and if it flips, then it is nicely managed.